I'll share my screen first, and I'll start
over to
talking.
you.
Then that's probably
Thanks, Adam.
better. Okay, guys. Have they come up?
Yep.
So let's share.
Yep,
I've lost
full
you
screen
all on.
now. Yeah.
I've lost you all on screen now, unfortunately. So if anybody has a question, Amy, will you just let me know?
Of course. Yeah, no problem
Yeah.
at all.
So nice to see you all. Nice to meet you all. Those that I've not met before. I'm Adam Johnston. I work in the Health and Care Partnership within North East Lincolnshire as the programme manager for Frailty, being one of those, and the other part of that is what we call integrated neighbourhood teams. So I'm going to give you a little bit of an overview of the work we're doing around frailty and how that links into some of the national work, but what that means for us locally, not just in North East Lincolnshire as well, but frailty spreads across Northern Lincolnshire, so that footprint. And also then the last few minutes talking around the National Neighbourhood Implementation Programme, which we've been fortunate enough to get locally here in North East Links. So I put Frailty North East Lincolnshire. I've also put cohort 4 because there's different channels in which you work within, and PEOLC stands for palliative and end of life care, which for a lot of people that are severely frail in North East Lincolnshire, that's what that comes under. So there's 4 priority cohorts that we work towards within the Health and Care Partnership, and living with frailty, ageing and dying well is one of those. There's a lot of work going on around the term frailty, as you mentioned at the start, Amy, and whether that word and what that means to people in our communities. And we know actually that using the word frailty doesn't help. So I'll share something a little bit later on around how we talk about that, how we promote it, and what we do with the word frailty and that term. But within a medical setting, in a clinical setting, really important that we're able to distinguish so people are getting the right care as and when they need it. You'll have all heard, hopefully, around the NHS 10-year plan and what that means. I've picked a couple of bits out in relation to what does it mean for frailty. Well, frailty is recognised as a priority for integrated, proactive and personalised care in the community. What does that actually mean? That we're working with people from a person-centred approach, that actually they're being supported and cared for in a way that means they can be more independent, live longer lives and away from the hospital and more towards their home, which I think is really, really kind of key. I just mentioned about the hospital at home, and it's something around the modern service frameworks and linked to a case study in York. There's a frailty hub in York. Tom, I'm sure you've heard of that actually, and how that brings together a hub around adult social care services to support people. And we are working towards an integrated frailty delivery model within North East Links at the moment. I won't go through those bits, but there's a bit around the strategy and what that means for North East Lincolnshire. I thought I'd give you a bit of more of a medical definition of what frailty is, just something to think about. But what we're actually saying is that people that have less mobility, for me, not just around the physical resilience and vulnerability of that individual, but the wider ones of those as well. So their social interaction, their relationships, the places that they live and how they get around, that impacts on their ability to live independently, or that their health deteriorates in a way where they can't look after themselves effectively. I've put a little bit more at the bottom there as well, Amy, and the links to that so people can have a look at those later on. But interesting statistic for you that around 50% of people over the age of 65 are living with some degree of frailty, and some who experience frailty even earlier in life. In North East Links, the youngest person that sits within our frailty register, I think, is 34. So it's a significantly low age for somebody with frailty. There's a couple of bits that's linked into what do we define as frailty, and the British Geriatric Society refers to 5 frailty syndromes, as they call that. I don't really like the word syndromes either, but falls is obviously a huge one of those. So collapse, legs giving way, found laying on the floor as a way of determining whether somebody would be the immobility of somebody, delirium, so acute confusion, muddled, incontinence, and then lots of work around being more sensitive to medication and side effects. So there's lots of conversations within frailty services and models around polypharmacy and what medication the people are having. A really good example for that would be around blood pressure tablets. If somebody's more likely to have a fall or is unsteady on their feet, and yet they're on medication that maybe reduces their blood pressure, for example, that there's a more risk that they might be able to fall. So it's important that medication is reviewed. What does the picture look like in North East Lincolnshire? Well, these figures were done in March. They're actually just being rerun at the moment, but hopefully they give you a bit of a picture of what it looks like. So around 20% of our registered population in North East Links are at risk or are living with frailty. So through the GP practices and System 1, there's something called the Electronic Frailty Index, which is our indicator, not a diagnosis of, our indicator of how many people are living with frailty in North East Lincolnshire. So approximately, as you see at the top there, there's around 23,000 people with potentially mildly frail, a further nearly 9,000 that are moderately frail, and a 3,500 group of severely frail, which a majority of those would be palliative and end of life. So a real significant challenge for us in North East Lincolnshire. And if you know anything around the demography of North East Links, the ageing population is only getting higher and higher as we move through the years. So really important that we start to think about how we're supporting people within frailty, but not just those that are, the prevention and proactive elements to that as well. The next slide, I'm sure our colleagues on the call, Mike and others, have seen this a lot, but I think it's really important that we highlight the level of healthy life expectancy. So the diagram there shows only the last 10 years around healthy life expectancy for people. When we say healthy life expectancy, I don't mean when people die, it's actually living a healthy life. So maybe developing a long-term condition or living with an illness or diagnosis for the rest of their lives. And that age within North East Links is 54 for both males and females, so significantly lower than our national averages. What does frailty look like in North East Links? Really thought I'd try and help and shape into what services are available from more of a medical perspective than anything. But we have 5 PCN. So PCN is primary care network. So that's all our GP practices sit under a primary care network. So there's 5 teams in those centres. They work by identifying people through the AFI. They do all what we call clinical assessments. So the term for that is a comprehensive geriatric assessment for people that are moderately or severely frail, and that's where home visits happen and that kind of work. There's the Care Plus and the Community Urgent Care team. So there's a 2-hour urgent response for people in the community. If the GPs aren't open, something happened to somebody at the weekend, excuse me, there was a call made for people to go out into that. So the kind of the out of hours response to support people. And then our NLAG, so our hospital front door frailty response team. And that's where somebody gets an assessment within the emergency department or in what they call SDECs, that's same day emergency care teams, to support them with frailty. And that's kind of the approach that we have locally in North East Links, as well as supporting our other community services and teams, which I've noticed my diagram's not that clear, so apologies for that. But we have the falls preventions team, there's the virtual wards, so step up and step down in hospital care, which links getting people back to their homes as quickly as possible. Excuse me. And then there's obviously a lot of work that goes in within our adult care and social care sectors for supporting people and where they live and what support and help that they can get. A little bit on the programme vision there, but I'll let people read those. But as I mentioned at the start, I think it's important to recognise it's mainly about enabling people to live and support themselves in a better way in their home or environments where they feel safest. The delivery plan does have five priority areas. So one obviously being prevention and education. The other one around that proactive care. So understanding how do we assess and support people earlier on to prevent that risk of falls or somebody coming into crisis. The out of hospital element is really key. And there's a whole agenda around deconditioning at the moment, which is another part of the plan, but also on how do we support people to get better care at home. So hospital at home is a term that's used at the moment to support people in the places where they feel better, and to get up, get dressed and get moving as part of that package. What we mean by that is that the longer somebody stays laid in a hospital bed, the less likely the chances of them are to if you like, almost recondition and go back to function in a way that they did before, which obviously we would like people to do. There's obviously the hospital model and pathway. So how do we support people to get the help where they want to, as well as getting them back into the community, and deconditioning, as I've already mentioned. What difference does that make? I'll quickly just talk about a couple of those. I think it's really important, is that we want to increase the recognition and consistency of frailty much earlier on, and recognise and enable people in our communities to recognise if there's challenges for people. I'll speak about the Frailty Sector Network in a minute, but there was a huge conversation at that network last week around signs and symptoms and spotting earlier on. So things around sight and vision, things around hearing, and people's ability to make judgments. So if they're driving or if they're walking and feel and their balance is not right, then that's the signs and symptoms there. We should be taking notice much earlier on. And then also there's a at the other end of the spectrum, the bit around people are supposed to be discharged back to the usual place of residence or care, and that we're not removing people's independence and ability to look after themselves within that space as well. And I think there's a space and a place for some training education in this, not just for staff that work in the hospital or within our services, but actually for friends, families and carers of people as well, that often are caring for people and wanting to do things for them because they love them so much, but sometimes stopping that person from recovering fully as well. And just some food for thought there. Something to talk about then would be around the Frailty Sector Network and developing an integrated frailty service. So when we talk about developing an integrated frailty service, we mean something that supports people holistically, is person-centred, but it makes our services work in a more connected, a joined up and also flexible way. And that's based around 10 principles to care. And these come from the British Geriatric Society, but are also underpinned by the Humber and North Yorkshire Clinical Frailty Network, and some work done across over in Hull through the Jean Bishop Centre, which has kind of got a lot of recognition nationally for how frailty is delivered. And they're the 10 principles there which guide us and support us, and we work towards locally here in North East Links as well around how we support people with frailty, from the consistent identification right through to the right dedicated clinical and strategic leadership. More challenging at that end. For example, we don't really have any consultant geriatricians in North East Links, and we often have to speak to other colleagues in different areas to get the support for that. But at the same time, making sure that our teams in our primary care networks and others have the right training and skills and sets to be able to support people effectively and make those links into our community settings. So what does that look like for frailty and the model within North East Links? Excuse me. Just try to show very quickly on a screen there what that looks like. So if somebody is fit and well and doing good within their lives, that we are thinking about how are they aging healthily, what's the prevention work that we're doing, who are the areas and people that we're working with, so our public health colleagues, our voluntary community sectors, the screening that's done out in the communities, or when you might see your GP, even if it's for a cold or something, and ensuring that everything else is working okay. For those with mild frailty, so we're going to treat or try to treat some of those reversible causes, introduce more exercise, physical activity, nutrition, the medication reviews, and if appropriate, look at that comprehensive geriatric assessment for those people that it might be most impactful for, and then link that into wider services as well. If there's other conditions that sit alongside that, for example, maybe diabetes or whatever, our social prescribing teams could pick that up and link it together. For those with moderate frailty, again, the reversible causes, very similar to mild frailty. They may be more linked into some of our community services, definitely at general practice and support for that. And also our PCN frailty teams, the nurses there will support these people to ensure they're getting the right help and support. And these people will be reviewed on a 6-monthly basis and checked in that they're okay. And then there's those at the top around severe frailty. So they've had that assessment. There's been medication reviews. There may be advanced care plans. There may be palliative and end-of-life plans put in place. For people, there may be what we call respect forms. So understanding where somebody may pass away, where they would like that to happen, in what way, and who that's supported with and around, so that it's the best possible care for an individual once they get to that stage. So What does that mean and what work have we been doing locally in North East Links to deliver frailty? Well, obviously we've developed that vision I shared earlier on to you. I'll briefly jump past that. We're developing those opportunities around early identification. In April this year, we developed a standard operating procedure, and there was a new spec around frailty so that we could be consistent in our approach across all the primary care networks. So each person, regardless of where they live in North East Links, should get the same level of care across the whole place in terms of who they see, how they access services, the assessments that they receive as well. And then in terms of developments for the system, we obviously link into the palliative end of life. We've done a lot of work around mapping our services to understand where they cross over, or where we can make better connections so that people can get access to those much quicker, and our services become more flexible in terms of demand. There's lots of work going on around the levels of referrals, because for somebody, particularly if they're severely frail, if you get referred to another service and you have to wait 4 to 6, maybe 8 weeks, there's a lot that can change within that time, particularly if there's been a stay in hospital. So it's important that we reduce that demand failure, if you like, for people. And that we've co-designed with the future delivery model and local workforce and with local people. And there's been elements of the Frailty Sector Network, and we held a clinical network only a couple of weeks back to look at the ways in which people access services and how and what support they can get. So what are we trying to do? Well, obviously create, or what are we trying to change? For me, there's 4 strands to this. One is around the community, so focuses on enhancing the quality of life and independence for our people within North East Lincolnshire, regardless of where they live. Individuals, so the person-centred care, effective communication for people, and not just the person or patient, but actually for carers, family members, and those that are closest to them. We've spoke a lot within frailty around some people that are isolated or lonely, actually that their main carer or person they have the best relationship with is often their neighbour or somebody in their street, not necessarily a family member that could live miles away. There's some work around the workforce, integrated holistic care, and bringing services better together to work more efficiently. And then how do we create the right pathways and connections to make sure that healthcare remains efficient and effective, reducing things like demand for people, and also how people access the services at the right time for them. Okay, quick pause. As an aside to that work, then there's a piece of work called the Frailty Sector Network. I know, Amy, you've been to this, and other colleagues may have been to this on the call as well. I don't know if anybody else has joined, but I set up a Frailty Sector Network, which happens, quarterly, and it's the last Thursday of that month. We actually currently run it at the minute through the potting shed at Grimsby Garden Centre, and we have between 30 and 60 people, depending on what's going on for people to attend that.
It's really well attended, isn't it, Adam? It's really well attended.
Yeah, we've got kind of 100 individuals signed up to it, but to say we get between 30 and 60 face-to-face, I would say it's a face-to-face meeting. I just refuse to do that one online, because I think I would like everybody to try and do some of that work together, but again, that brings its challenges. From 20 plus services in primary secondary care, the VCSE, the fall service, the fire service, and many more come along to it. But I found some of the best and richest parts of it aren't always what I talk about. It's what the services present and how they work together, but also the conversation that happens in that room. For example, we were talking about deconditioning last week, and it brought to the attention to lots of people in the room around where people live, the levels of activity, the dark nights. It brought around sensory, so the hearing, the sight stuff for people this time of year, isolation, loneliness, and I must have made a list of about 25 different things to follow up on. But it's just really, really, really rich in terms of conversation, how it supports people. We've also used that sector network to map people's journeys, whether they're mild, moderate, or severe, and done round the table kind of discussions within that room for different services and thoughts around. So if somebody accesses your service, where do they go? So they can start to do things like minimise the handoffs, do better handovers in terms of services as well, to develop a more more, if you like, robust and resilient future model. Excuse me. So what does the roadmap look like? Well, we've been working through this since May time. We're currently in that vision and model development and working through that phase now to the end of this month. And then we'll be starting to look a little bit around some of the digital and the impacts of that, and how are we going to scope solutions that support us moving forwards. And then looking at how we implement something new towards the end of the year, if that's appropriate or not, or that we stay as we are and we look to develop some of the changes to make it work for people. So that's kind of where we are for Frailty, I think. We've done a couple of bits around supporting people out in our communities. You mentioned about the language earlier on, Amy, and we didn't want to put on here, are you frail? We want to ask people, are they lonely? Do they need any support with their care, their diet, their exercise, or their mobility? And if that's so, that could lead someone to becoming frail in the future. And that's some of the feedback we got from some of the patient participation groups. We did one with GP practice. I've done one which is a community session that happens at a GP practice, which is a coffee morning, and some dementia groups as well. And the feedback from the patients is that that's much better language for us to use than it is to call somebody frail. And that actually, when we talk about identifying people as frail, people, if they're struggling with their balance, don't see themselves as frail. They see themselves as having difficulty with their balance. So it's just something to think about in terms of how we speak to people. But this was also around for people in our communities to access some training, and also for our professionals and services to access training as well as linking into our community services such as Connect NEL, etc., to support people as and when they need it. So that's in there. You can scan the QR code. You can do some of the training yourselves. And there's different levels and tiers within that. So by all means, once you get the slides and everything, have a scan, have a look. This was a question just as a food for thought for you all, really, was how can we raise awareness and recognition of frailty within our organisations and the people and communities we support? Often we think outwardly within our services, but we don't think about our colleagues and friends around us as well. So that's something I'd like to put into your minds around how people maybe even access work and remain in work for longer so they can remain independent. Not just physically, financially, etc. as well. I think it's really, really key. And when we talk about the healthy life expectancy at 54, many people will be working in the future until they're at least 65, if not longer. So we've got to start thinking about this in a different way. And I've mentioned deconditioning a few times, and I just thought I'd pop this slide on the next one just for you to kind of show you an NHS special offer for somebody that's an older person with frailty that maybe spends a week in hospital, the impacts that this can have, excuse me, on somebody. So if you're in hospital, you have a fall, you may have to stay in there for a week whilst you recover. The NHS special offer is you'll get 20% off on your quads and power to stand up, or maybe be mobile in terms of getting up and down stairs or whatever it is in the setting which you live. You'll potentially lose up to 1.5 kilograms of muscle loss and 10% off your aerobic capacity. So not only have you now got up the stairs, you've lost muscle mass, which is much harder to get back as you're older, and your level of fitness. So you might be gasping for air more, which feels really uncomfortable in terms of supporting yourself just after 1 week of laid still in a hospital bed. I think deconditioning is a huge agenda for us to think about, as I said earlier, not only for our services and professionals, but as an education tool for our friends, families, colleagues, in terms of how we're supporting people and enabling people to recover from a fall, or support them in terms of their reconditioning if they are or have a diagnosis of frailty. I'm going to pause for a second there in terms of frailty. Is there any questions from anybody?
I had a thought, Adam. I'm not sure if it's a question or a thought, or Amy's thought. So you were saying at the beginning around bladder frailty and that people needed support with that, and then we spoke about some young people now in their 30s. Would that be connected with ketamine, with the use of ketamine, or do we ever think of it like that? I thought, well, Mike's here. I didn't know if that links in with any of Mike's work as well, but I know I've spoken to Nathan Smith at Navigo and others, and obviously the use of ketamine is so high within younger people, and one of the big things is you lose control of your bladder, don't you? And I just didn't know if that was the connection with the one being in their 30s or not, or if we look at that.
I've not properly looked at the information in relation to that, Amy, but I guess it could be. I'd take Mike's lead on that.
Yeah, it's interesting thought, isn't it?
Yeah, it is. Thomas?
Find the right buttons to press in the right order. It's not as interesting a thought as that, unfortunately. I'm a bit geeky. I like numbers, so I was really interested by the 20% of the population identified as frail by EFI. So I thought, oh, while you're doing that, I was like, oh, right, that seems quite high. I wonder what York is. We're 18.1%, so less than you, but not quite the 8%. And then it got me thinking, oh, well, we know EFI's, it's all right, innit? It's not great. Apparently it's an 84% efficacy on it. So you could probably do 84% of 20% or whatever the total number was, and that would give you a closer to true picture. But no, I found it really interesting. I presume the teams now are moving towards the Rockwood scoring system as opposed to EFI.
So yeah, maybe I didn't mention that earlier on. So yeah, the electronic frailty index is an indicator. It's not the diagnosis of. But if somebody is on the EFI, has a whole host of other factors that link into it. So if you are more likely to fall, if you have diabetes, if you have high blood pressure, the EFI puts all those markers into a score and says whether you are mild, moderate, or severe. Does that make sense? And then if somebody comes through as moderate to severe, that's when the teams will step in and do that comprehensive geriatric assessment, that frailty assessment for somebody, and then they will get given a Rockwood scoring at that point. Although there is other tools that you can do within the community. So there is actually an app called the Clinical Frailty Scoring app, and you can go on the app, download that on Google, and you can answer some of the questions, and it give you a bit of an outline of whether you think somebody's mild, moderate, or severely frail. So there's tools out there that we can use as well. Sorry, Katie.
No, you're fine. It was just more of a comment, I suppose. I'm the other end of the spectrum for my role's children, young people's long-term conditions lead. And obviously frailty for me, we still have very frail children, particularly when I'm thinking of our children that obviously still receive palliative and end-of-life care for many years. And I suppose my interest was kind of where some of that obviously links in, and obviously in your presentation you mentioned around palliative and end-of-life care, but particularly for me, I suppose, with my children's hat on, would be around that transition into adult services, and kind of, I suppose, what we know that's a really vulnerable time for our young adults, isn't it? Kind of going into those years, and I just wondered whether you had any kind of data, or whether it's something just to, I suppose it was more, like I say, more of a comment really than a question.
Yeah, I think it would be something more for me to look into. Obviously, I do spend much more time with our older people.
I appreciate that.
I absolutely hear what you're saying there, and if somebody's moving in, I guess it would link into their advanced care plans, where they're shared, how they're shared, the work and development that goes across, and making sure that transition would be smooth. But yeah, no, it's something that I'll take away and make sure is in my mindset for sure. Yeah. Thomas?
Thanks. Can I ask a follow-up question about the sorry, I'm like a dog with a bone when you give me something. Okay. Right, so mild and moderate, are they the groups who receive the comprehensive geriatric assessment?
Moderate to severe are the ones that will receive the comprehensive geriatric assessment. In the mild, it will be, I mean, there may be a case where it seemed that somebody would need one, depending on when they speak to them. Because what I would say is sometimes a team might visit somebody that's been through EFI that is identified as severely frail, but when they get there, they're actually managing really well, and they may not, even due to the conditions they have, may not be severely frail. Does that make sense?
It does. Yep. So I guess the reason why I'm asking, I'm looking at the data for York, and if we just took moderate frailty,
Yeah.
there are almost 10,000 people who have a moderate frailty code, moderate frailty EFI score, not coded. Apologies.
Yes.
So what's the sort of scale of this team, and how
Yeah, well,
can
no,
you
the
possibly have
scale
capacity
isn't
to...
massive, and I would say that if we're being brutally honest, they're not going to. So the 8,500 people locally, they're not going to get through all of those within a calendar year. So what they're looking at is the scoring, the severity. Sometimes it's picked up in other arenas as well. So if somebody presents at GP themselves, excuse me, and across the system, they'll be picked up and then passed to the team to do that frailty assessment, but they won't be trying to contact all 8,500 people, if you like, across North East Links in one go. It's impossible. And I'd say that's the same for, well, I know within the York Frailty Hub, they saw around 3,500 people last year, which is still an obscene amount of people to see. So it's managing best that it can be. Does that answer your question?
It does, yeah. So the refer,
Yeah.
so it's more a case of, rather than proactively finding people based on EFI, it's a referral-based system. People referring to the team,
Yeah,
and
it
then
can
getting
be.
in touch.
They might find some people they follow up with, particularly from a proactive and early identification. So I'm working within one of the PCNs at the minute around an integrated neighbourhood teams approach, purely around frailty, and we have developed this is for those that are on the EFI at a mild level. Just a questionnaire developed with patients around how's your life, how can you get out and go shopping still? Can you do all those lifestyle things? We're not saying this is a frailty questionnaire. It's more of a health and wellbeing one. And if people are scoring high within those responses, then they might need a call from one of the PCM frailty nurses, from one of the GP practices, and just a bit of a follow-up call to say, okay, let's have a chat about this, and then decide if there's an assessment that needs to be done. So it's just trying to do that identification bit a bit earlier.
Yes, it's so difficult, isn't it? And so, sorry, just the scale of these things are so difficult to tackle, because, you know, it's great, I guess, if practices are proactively writing out to people in the mild range, but if you've got 20,000 people ahead of them in moderate or severe, then you're sort of turning up to a earthquake with a dustpan and brush, aren't you? So how do we meaningfully make a difference? And I guess these are things we're all sort of tackling.
It's both ends of the spectrum, isn't it? It's we have to try and support them, and we're always going to have to be reactive in some sense. But I think that there is some, or from my public health background, there's something in the more proactive that we can be, the less we'll get further down the line. Although it doesn't change today's problems for tomorrow, does it? So, yeah. Thanks, Tom. Kat?
Yeah, I just wanted to ask if people can go on and off this frailty register, because I'm thinking if you're talking deconditioning or if you're talking prevention, and obviously people have hip replacements, knee replacements, and all sorts of interventions. Are people? I suppose the goal is to get people off the register or prevent people going on it. Is that going to be a measurable in the future, that people actually fall off this frailty register?
Yeah, and people will move between mild, moderate, and severe potentially as well. So sometimes episodic care can have obviously an impact on that. But in terms of when we talk about it as a frailty as a long-term condition, if they're on there, then they're probably going to stay there. Kat, the level of which they function and support and remain independent, etc., will be recorded through their assessments, and supported in that way. But if it's an episodic piece of care, then somebody may just move back off that again.
Okay.
Yeah.
Okay. Thank you.
Mike?
I thought I'd better answer the question.
So,
So in terms of ketamine, it's highly likely, but there is a piece of work ongoing at the moment across the whole of the Humber. So there's a ketamine working group that's taking place across the Humber. I'm going to throw that into them just to see if there's anything that's been done on it, and I'll let you know. It would make sense in some ways. It's probably not the right phrasing, but in terms of those who have got long-term damage and how that then will affect their levels of frailty. I think the other thing just to say is there's some education in and around pain for people and how we understand pain as individuals, and what it actually means, and what a medicated approach as opposed to a non-medicated approach, and so on. It was quite funny because Adam knows this. A year ago, I ruptured my Achilles, and it's I'm still not there, and that's over a year ago. But what was interesting was I had being me and the job I do, I had a chat to my physio and kind of said, how am I doing, in terms of this? She's doing very well, because most people don't do any of the exercises. And I kind of went, well, why is that? It says, because it hurts. But if you don't have that level of pain to push it forward a bit, then you will end up not having the movement you had before, which I don't, but even less for that movement, and then that would go towards that frailty score, as an example. So it's all those kind of bits and bobs. So and I mean, again, little exercises you can do. Some of us are in the older age bracket, you see, so I all of this is very relevant to me. But things like brushing your teeth and standing on one leg.
Yeah.
You're kind of like, what? But yeah, it's just a thing that you can do that that increases your balance. It helps you with your balance. It depends if you've had a drink beforehand, but I mean that's a different conversation.
Sure.
But yeah, so there's various elements, and I think that's the bit where the public health element comes in, is in relation to that population level move and how we do that. I haven't got the answer to that yet, but
some of that might links into the get up, get dressed, get moving kind of idea and campaign and suggestion, is particularly for families and carers. I think for most of us who we've cared for a loved one at some point, and we often take away a level of responsibility from them without realizing, because we don't want them to get hurt, or we don't want them to fall again, or we don't want them to be uncomfortable. With the best intentions, but actually what we do is start to decondition somebody through love sometimes as well, which is a really difficult thing to think about, but it's essentially the truth. I've seen it in my own family, with my mum and her mum when she had a bad fall, and my mum ended up caring for most of the time, even to the point where my nana, as I'd call her, wouldn't even lift the kettle up full of water. She didn't have the strength for it anymore. So it's important we start to recognise some of that stuff. Sorry, Tom, I've realised you've had your hand up again, mate.
No, I'm just gonna waffle on about boring stuff to do with ketamine bladder. So, according to ChatGPT, EFI is made up of 36 conditions.
Yeah, it is, yeah.
Each condition is worth either 1, i.e. it's present, or 0, it's not, it's absent. And then you divide, however, you add up 1, okay, yep, they've got incontinence, 2, they've got a visual impairment, 3, they've got a hearing impairment, and you divide it by 36.
6, yeah.
So if you divided 1 by 36 because they had incontinence, there would the chances of them ever being able to get up the frailty scale based on incontinence alone, it's impossible. Yes. So I think you would only be considered frail if you had a number of other long-term conditions as well. Now, having said that, if you were to use the Cambridge multimorbidity scoring system, incontinence is actually much higher. It's a weighted system, so each condition, and there's only 21 of them.
Yeah. Well, I'm going to give you a bit of information on EFI there, Tom. So there's an EFI 2 potentially being rolled out nationally, where each of those elements will be weighted. So very much along those lines of the Cambridge model. So it should make a more of a accurate, if you like, stance for individuals. Yeah. I like your research, man. I didn't go into that detail today, but it's good. Chat GPT is awesome as well. But that's what will be happening. An EFI 2 should be coming out. Yeah.
Fascinating stuff, isn't it? Really interesting
conversation. I'm dead chuffed with the questions as well. I'm sure if we get them today, it's great.
Yeah, no, it's really good. Makes you think though of all. And I think the other thing for me, what I did at the Frailty Network, and obviously with the community plan, there's community frailties in their mental health. Do people feel safe in different communities? The house adaptations for older housing and terraced housing. Are we making sure that people can get in and out if there's steps, are there adaptations, are the stairs really steep in these older housing? And that made me aware actually of what we're doing within the community in the plan, and how you can add a lens of frailty onto that, and then you kind of get different data, so to speak, from the information that we've been looking at. And that's something I'll be doing for the West Marsh plan moving forward, because we know that's got an older population of single occupancy as well. But yeah, I think it made me realise that you can have emotional frailty in community, and how do we adapt these old terraced housing, or the housing that kind of is behind Tom in the picture, to ensure that it's adapted for frailty. And the other thing that came through a lot of the community plan work was people that do have disabilities. It's really hard to get their houses with adaptations. So are we penalising them if they can't have a hoist or a stair lift or something like that? And are we making them more frail by living in a front room, not being able to access the whole house? So that really made me think about how we're applying community plans as well.
Yeah, and then there is the whole bit around the emotional frailty as well that you shared around relationship, context, importance, independence links into that as well. So it's really kind of high. Sorry.
Go on, I've got one. I've got one more. Okay, this one's not about data. It's about everybody's favourite topic, money. How's this being funded? Where's the money coming from? How are we paying our practices and PCNs, who are, you know, independent businesses, to be able to do this work?
So the money is obviously funded through the ICB to our PCNs around delivering frailty in North East Lincolnshire. For our wider services, and depends on which services you touch, but you might end up at the Alzheimer's Society, whatever, they're independent organisations. But other than the money that goes to PCNs to support people, we're then reliant on our services and wider referrals that pick those up. I don't have a budget of millions of pounds that I can go, oh, let's do X, Y, and Z. It fits within the current care system. That's how it's dealt with.
So the PCNs have a specific contract where they're getting money to deliver frail
the
care.
PCNs get a bit like they do with other conditions and illnesses as well. Yeah, so it's picked up. So they have the frailty nurses within their settings. They'll have a GP that sits as part of that time, and then they'll do the assessments, etc. that link into that. Yeah, slightly different to how it works in York, because you just have one team that's subcontracted that sits in one place for frailty. Yeah, and you have your GPs and your consultants and everybody that work within it.
So I just suppose, you know, is it a local enhanced service that the PCNs sign up to? Or is that...
Is it a LES? I think it probably is. I'm not 100% sure on that, actually, whether it's just one of the set contracts that's reviewed so often, but I'm not sure if it is a LES. Just that's my honest one. I'd have to speak to Debbie about that. Debbie Jewett, who does all the contracting and commissioning for the ICV.
No, just interested. So it's all about value for money.
Absolutely,
as well,
value for money. Yeah, that's the point. That's the point, isn't it? And that we make sure that we're getting enough reviews, enough people are getting the care, the right care they receive, people are being assessed effectively, and so on and so forth. And that's something that is reviewed on a quarterly basis around how the PCNs and the networks are doing around assessments and supporting people. It's something that is reportable and reported back on. Same as we'd expect around admissions to hospital and that kind of thing as well, from the severe end. Yeah. Cool. Do you want me to just do a quick 5 minutes on the National Implementation Programme, Amy, just to follow up? Yeah.
Sorry, I lost my mouse. And yes, please. I think that would be really interesting.
Right?
Yeah.
I think my screen's been sharing the whole time, hasn't it? But I have been looking at you on screens. I'm on two here, so apologies. That's still there. I put a couple of slides together. Is that just moved across or not?
Not yet. We're on the thank you and get in touch.
Yeah, get in touch.
Your little brain light bulb.
Okay. So if I move across now, has that come on?
Yeah.
Brilliant. So have you all heard of the National Neighbourhood Health Implementation Programme? I'm assuming you say yes or no. I don't know because it's just jumped up on my.
Everybody is nodding, Adam.
No, that's
Everybody
good
is
then.
nodding.
So we're fortunate enough in North East Lincolnshire to be one of the initial sites to develop that. So I just thought it'd be useful just to give you a bit of information of what it is. Initially, I was talking about national pilot implementation program, but they've asked us to remove that word pilot away and think about this as a program of work that will develop over the coming months and years to be just a way of working and what we do for the future. So it's a transformational initiative, obviously led by the Department of Health and Social Care. Yeah. The main one of those is around what's in the 10-year plan, that shift of focus of care from hospitals to communities and from treatment to prevention, and how it supports people within our that have complex needs within our deprived areas. So our site of focus, if you like, area of focus within North Links to begin with is based around a PCM footprint, which is Meridian PCM, which if you know Grimsby, Cleethorpes, Immingham, that is the Roxton practice, which is Immingham, and then there's also Open Door and Quayside that sit with part of that, which is part of Grimsby in our East Marsh area. That's right, isn't it, Amy? East Marsh.
Yeah.
Yeah.
And then you've
Shall I
got
get that?
Wheelsby View that's
Which has got a little bit of that in there as well. Yeah.
yeah, no, it's Heneage, isn't it? Wheelsby View,
Heneage.
which is the borders and is almost on that cusp as well, isn't it? It's really vulnerable. Yeah.
Yeah. Well, in terms of our, if you like, deciles of deprivation, they are fairly high up within those scorings. And as it talks about, it's a national movement for neighbourhood health. So it's about combining that local action with national learning, and that we're working together to do that. I thought it'd be useful if I picked out, excuse me, the points from the 10-year plan and the neighbourhood health service out of hospital care. So the key theme is shift from hospital-centric care to community-based integrated neighbourhood health services. I've put the link in for the 10-year plan on the bottom of the slide there. So where I've put pages and numbers, you can reference that later on if you want to. But the vision and rationale is that it recognises that hospital-centric care is fragmented, it's difficult to navigate, especially for people at disadvantage or with complex needs around where they go next or how they're supported. So that the aim is that the new model brings together those people and services and teams with a focus on prevention, but actually personalisation of care for people, so that they are also in control of what happens to them and where they go as well. There's the development of the neighbourhood health centres within that. I can't answer you any questions on where that might be, what it might look like. Will it be a new building? I'm pretty sure I could say it's probably not going to be a new building. There isn't a lot, millions of pounds that have come with this either, but there's for us to explore assets, services, partnerships, where we might be able to develop neighbourhood health centres within our communities already. Where people are, where people will go, I think is really key. I know from the work that Amy's done in the East and West Marsh and the community plans and presentations I've seen Amy do, is that if we're not actually going to be in the spaces where people go, they're not going to access them. And actually some of our infrastructure locally in North East Links around transport, etc., doesn't support people well enough to be able to access something in a different area. But the point is that these will be kind of one-stop shops for patient care. They're open at least 12 hours a day, 6 days a week, and will be multidisciplinary in terms of the people that sit within them. We talk about the investment shift over the next 10 years, especially the next 3 to 4 years, from hospitals to hospital care being outside of that, with an investment in community enabled services. I guess that was challenged, Thomas, that you were talking about in terms of how people get the receiver proactive and prevention and versus those in the severe. And I think that'll be a conversation and some challenges that happen through this programme of work as well. But I would say it's for North East Lincolnshire, we're basing it around long-term conditions, people with many long-term conditions. And then personalised care and digital support. And there's a review around the NHS app and how it will enable people and patients to book and support with people, and how we might develop that alongside it. And the links into community pharmacy. So playing a bigger role in managing long-term conditions, prevention, and linking to single patient records. Excuse me, and enabling people to, I think, be better seen across the system instead of lots of different services using different systems. So what's involved? Well, there'll be integrated working, co-production, shared leadership for this. We've already started to develop this work locally around what does our neighbourhood place team look like. We're working to look around delivery huddles, so daily huddles and fortnightly huddles to support those settings and people in our communities around being reactive to care, but also being proactive in support. We're just currently co-designing the goals and the delivery plans, and really meeting on Thursday this week actually to really look at our what they're calling a 360 assessment of where we're currently at and how we identify and support people with long-term conditions. So we'll be formalising and scaling that approach. We'll be looking to improve the outcomes for people with multiple long-term conditions whilst reshaping the way that funding, workforce and estates to make sure we sustain that left shift. And there's 6 real key ways it will make a difference for people and communities that's come through the national programme. And this is the 6 that sit underneath that. So 1 is making it easy to see your GP, so helping local practice have more time for people who need them most. We have done a huge amount of work on that already around people that attend practice a lot, how they use practice and how they use other services. So that will feed into this work. Number 2 is around providing more care in the community. So hopefully keeping people out of hospital. And with hospital only for treatments that can't be given elsewhere, we have to make sure that we're developing the service in our communities that pick that up. Focusing on those who need extra help. Acting early, not late. Again, that from fixing problems to preventing them, helping people manage their own health and giving people the tools and skills within our communities to do that. And then having one effective team around you that supports that. And as we've said many times, and Kat, you say it all the time within the mental health work that you do, but not having to repeat your story, I think is kind of an essential bit for that. And the last slide I wanted to share with you is that one more slide actually after this one. Apologies. Is so what are we targeting? Well, people with long-term conditions nationally. Some figures there for those that are like those. 17 million people are living with a long-term condition. Yeah, 9 million of those living with multiple conditions, and 2.8 million people out of work due to long-term sickness or disability. And a further just over 1 million are due to cardiometabolic diseases. So illness, long-term conditions, multiple conditions, or long-term sickness equates to a significant amount of our population that need support or extra care, and whether they're getting that is the most effective it can be is really important for us to think about. Talk about the modifiable risk factors. So 70% cardiovascular disease, 80% of diabetes is preventative. So you need to think about the opportunity to, as they talk about bending the curve or turning the curve through prevention rather than management of a decline in health, which I think is a real shift in focus for the programme and for our colleagues that are working within the health sector. And we'll identify a cohort of people with multiple conditions using data locally. So, excuse me, the systems we've got locally are EMIS, System 1, but we've also got a database called Epiphany, which is a BI tool, which links into all of our wider services as well, such as mental health, adult social care, for us to be able to really get a cohort of people that we would like to target and work with initially within this programme, but that creates a model that's sustainable for the future and can work across all sectors and places. And then the last slide I wanted to share you was just to this one, sorry, just to say that this isn't about a new care model. It is about a radical shift in how we deliver care. We take the power from institutions to communities in terms of how we're doing it. As we said, we're one of 43 places. Some of the key goals specifically is around improving people's health and well-being, and reducing inequalities in healthy life expectancy, which we know in North East Links are much lower than the national level, as we've seen. And that we've got some real core ways of working in which we do that, and may link into things that, well, it will be around co-designing, working with our communities, our people, our patients that reside in those communities, as well as the practitioners, and something around how do we devolve or pull budgets or create new enablers to make things work, whether that's digital or through estates or whatever it is that we look at. and that we continue to use shared data and identify ways in which we support people, that we stop having the barriers and maybe bureaucratic systems which stop us from sharing information which could really benefit people within our communities, and that we can strengthen those community connections to bring better solutions for people. So it's a really exciting time. I'm really excited to get stuck into the National Implementation Programme, the work, and continue to build on a lot of the work that we've been doing locally over the last few years around integrated working, to see all of that come to fruition and make a difference. So if there's any questions on that, I'm happy to take those as well. I will stop sharing my screen, and the slides I've already sent to Amy so she can share wider for you to read and get all the other information. Thomas.
Yeah, thank you for sharing that. It's really interesting. So we have the same job title. I don't have the frailty bit, but I'm the INT program manager in York. So it's yeah.
We need to have a proper catch up there, mate, don't we?
Yeah, we should do.
Yeah.
Slightly jealous that you got it, and then HIP, but also I don't know, it's a bit of pressure taken off as well at the same time. So I guess a more like general question. So like, and I guess this is the question that I sometimes ask myself. Okay, right, we're going to identify all of these people with rising risk who have long-term conditions, and then what are we going to do with them? What? Because you said this is going to be radical. What radical thing are we going to do with these thousands of people that's going to save the NHS?
That's for us to figure out.
Because nobody's telling us. The NHSE aren't telling us how to radically, you know.
Some of my radical thinking, and I don't know if it's radical or makes common sense at the same time, but there's something for me about how we work with people, not particularly those that have complex needs, long-term conditions, and that instead of it always being a handoff or a referral, actually that we bring together a huddle approach, a neighbourhood approach of those services sit in the room and create a plan for somebody in the moment. So let's say Mike was referred to us as a complex person. Not saying that you are, Mike, but I'm just using it as an example.
Thank you, Kat. Yeah.
Yeah, and we would sit in a room ourselves, a GP, somebody from social care, maybe somebody from mental health services, or whatever services was appropriate for Mike, and then we would create that shared action plan in there. There would be no thing around data sharing because people would just have access to the systems. There would be nothing around what's the word, handoffs and referrals. We would just be able to get them in. So adult social care, we'll go out and see Mike on Tuesday. Yeah. Somebody from mental health service might go, well, we'll see him on Friday, and the plan's made in the room, and actually it starts straight away instead of it being 2, 3, 4 months later before somebody's seen everybody. That would be one of my radical shift ideas that I'd love to see happen.
It's a great idea. It's a great idea, but like
I've written the proposal and presented it to leadership already, so I'll share it with you.
How are all these? Who's paying for all these people to come in a room for it's a very expensive appointment that Mike's taking up, and also what about all the waiting lists in all of those services?
Yeah, I know. That's where we've got to get better with how we're identifying and supporting people, isn't it? For me, but what that looks like at the minute, I don't know. That's one of my ideas. It's that. Go on, Kat.
My question, while we're still on the same topic, is Mike in the room? Because that
Mike would be
really important.
Yeah, what matters to you conversation. We'll understand what Mike's needs are. It won't be a case of, well, Mike's got X, so let's deal with that. It's actually what's most important to Mike, and then let's get the people that we need in the room to support Mike. Yeah, that's the point.
I'm with you on that, Cal, 100%. Mental health services would run in the opposite direction, so there is that in terms of my problems.
It was interesting though, because last week I went to the Inequality and Equity conference, and there was Sir Michael Marmot, so I got to fangirl Michael Marmot, and there was also Lord John Bird. What an amazing guy! He's the founder of The Big Issue. And he's 79 and Michael Marmot's like 80 odd, but they honestly, wow. And I just think they're really interested in this and how that's going to work with the Marmot principle. And I think it gives North East Lincolnshire a real catalyst to look at the Marmot principles and this, and to kind of bring it all really all together and like give it a real like push. I've just seen Tom's comment. It was the founder of the Big Issue, but I didn't know, did he make the custard? Was he the custard? No, he wasn't the custard guy,
it was
was
just
he?
a terrible joke.
I thought it was, because I do remember my nana having it in the cupboard and where you make it from the thing, wasn't it? But both of those two were so fantastic in speaking about, you know, the big divides, what's happening, why we have money for wars and we don't have money to solve poverty. You know, it's really fascinating stuff in what they were saying, and, you know, and what the work, and then linking in with Lindsay and the public health team for Marmot Place. And I think there's a real opportunity to do this and the Marmot principles. And I think one of the big things that through the Marmot principles is obviously children and young people, and then you've kind of got racism, and then you've got housing, and I think they're the three that are on their radar to really, really start with. And obviously our housing stock is awful. You know, I don't agree with, well, sometimes Steve Ryder can be quite controversial in some local meetings that we go to, but in a way, if we had the money and you could knock it all down and start again, that's what you really need. But how can we do that? Because we don't have the money. Do you know what I mean? So it's a fascinating concept of how these two will really come together and really help. And I suppose you've got to think in 10 years' time, if the dial shifted, if you have Marmot Plays, you've got this, you've got that, and Grimsby's under a Labour government, we're doing quite well at the minute. So what is, if that doesn't change, what would it take to change the dial? What is the thing that will change that dial? Or will people always be in that kind of, you know, is it IDM1 because of where they are, how they live? People within, like, you know, homeless situations that all seem to focus in around the East Mash. You know, what will change that dial? And I think you've got a great opportunity now to see what that could be. Fascinating stuff. Honestly, that guy, if you ever get to see him talk, wow, I could have had him talking for the whole thing, bought him a beer. He was a great guy. Fascinating guy.
Yeah.
To answer that question, there will always be people in IMD1 because it's the entire country divided by 10. So it doesn't matter, even if the most deprived place becomes much better than it is now, it'll still be more deprived than somewhere else, unless of course we all just become equal, which would be nice.
Well, we just get rid of IMD and everybody lives where they live, and just have to improve the area. But it's quite clear for some of our areas that, you know,
universal income would be a very interesting. They've done that in patches in London, haven't they? And Lindsay was talking about how do we look at a universal benefit and an income and support people in different. It's just different. You've got to think differently. Because
I would say, though, I spoke to some of the frailty nurses locally about the people that they access, and even when they visit people that we would class are in our more affluent areas, some of the older people actually, just because they've got a really nice house, but they've not got a lot inside, they've hardly got any money. That it's they're more asset rich than they are affluent in terms of everything else. So it's interesting, really. We talk about poverty and what they've actually got to spend and live. So
fascinating. It is. And like I've always said, just because, especially with the cost of living, just because, say, I'm here in Haverstow, I have maybe a lot more pressure to keep up with my neighbours, keep up with my peers, make sure my children's got the right thing for school. That middle income is really squeezed. And how do you pay your mortgage if the inflation's going up again and stuff like that? So I've always said that middle income range is a really pressured and squeezed kind of community, really. But going off topic there, but it's really interesting. And this neighbourhood stuff is definitely on the radar of a lot of national conversations, not just within healthcare, but outside of that as well.
Yeah. Well, I hope what I've presented was useful. By all means, Amy, share those slides. Ask away for any more questions or get in touch. Thomas, it'd be great to sit down for an hour and just have a chat around INTs and the work and see how you're getting on there and what we're doing here. I only met with, Christine